All right, good morning. Welcome to Pediatric Grand Rounds. My name is Mary Leonard. I'm chair of the Department of Pediatrics, and it's my pleasure to welcome you this morning. First, we'll do a couple announcements. As always, there's a unique text code each week for Grand Rounds for CME credit, and you can just make a note of this on the left here on the slide, unique each week, and we'll also put that in the chat for your convenience. I'm really delighted this morning to welcome Sohail Husain to give Pediatric Grand Rounds, but first want to make sure everybody saves the date and is aware of the upcoming Pediatric Grand Rounds. Really important, one of our most important sessions is the Diversity and Inclusion Forum, and as always, we have a remarkable distinguished visiting professor. And on May 21st, we'll hear from Diane Chin from the Stanford Law School, Beyond Racial Justice Performance, Understanding the Role of Reflection, Context, Action, and Systemic Change. So very much looking forward to that event. And then the following week, I'm really delighted that Bliss is going to come speak with us. Catherine is an infectious disease expert in the Department of Medicine, but very passionate in particular about maternal and child health and infectious disease. We've had the pleasure of funding her through the Maternal and Child Health Research Institutes in the past, and she's going to speak about sweet therapies for sour immunopathologies in COVID-19. Next slide. And then again, showcasing the Diversity and Inclusion Forum next Friday. It's a full day event, 8 a.m. to 5 p.m. And the keynote speaker, as I've already mentioned, will take place during the Pediatric Grand Rounds time slot. And Diane is the Associate Dean for Public Service and Public Interest Law. Next, please. Okay, and it's that time of year when we have so many people to celebrate. So please make a note of all the different awards for faculty and awards for staff. We, very importantly, 2 of our awards for faculty are now named for our very distinguished faculty, the Fernando Mendoza Drive Award for Diversity, Inclusion, and Engagement, and then the Laura Bachrach Mentor Award. But you can see here, we have everything: basic science, clinical research, education, junior, senior faculty, as well as awards for our staff. This is such an important occasion, and we have so many things to celebrate this year. So please be sure to nominate some of the very deserving people for this award. And the nominations are due by Friday, June 4th. Next slide. Okay, so really my pleasure to introduce Sohail this morning. Sohail, I'm sure many of you, most of you know, is the chief of the Division of Gastroenterology, Hepatology, and Nutrition. He's also the Chambers-Okamura Endowed Professor of GI. He's the first endowed professor in the Division of Gastroenterology. So a really important distinction, actually named from the chair of our board of directors. So it's a lovely distinction. You know, looking at Sohail's CV, he's really the consummate physician scientist, very much what we're trying to promote and develop within the department. He had a KO8 Career Development Award, then he had an RO3, and then a series of RO1s, 3 different RO1s. As well as more recently, some very distinguished funding from the Department of Defense. And you'll hear about his passion for acute pancreatitis. His research is looking at 3 broad areas related to acute pancreatitis: the molecular and immune signaling pathways, the factors that turn on pancreatic regeneration and recovery, and the mechanisms underlying drug-induced pancreatitis. So thrilled that Sohail has come to lead our division. Under his leadership, the division is growing very rapidly and with great distinction, and it's been such a pleasure to watch the whole GI program thrive under your leadership, Sohail. So welcome. I look forward to your presentation.
Well, again, thank you for that kind introduction, and good morning. I'd like to especially thank you, Mary, for being a bedrock of support for us in the department and the GI division. Mary and the Department of Pediatrics are emblematic of a recurring theme of a shared vision and a team spirit that's woven into the story that I'll share with you this morning. And this acknowledgement slide at the outset attests to the value and breadth of this shared team science that went into writing the story you will hear about. The acknowledgements include current members from our lab at Stanford who are actively involved in the project, particularly Olivia Sai and Toshi Sato, who are pictured here. Former members from my time at the University of Pittsburgh and Yale who wrote chapters in this story that you'll hear, and the numerous collaborators at Cincinnati Children's, particularly Mayur Sarangam and Maisam Abul Haija and Anil Jega, At Rutgers, Tracy Anthony, Loredina Quadro. At the Dana-Farber, Louis Silverman. At Metabolon. At Pitt, particularly biostatistician Ying Ding. At the Stanford Metabolic Health Center, Kevin Contrapos, and numerous conversations with members of our own department, including Harvey Cohen, John Witten, and recently Tanya Gruber, as well as the Nordic ALL group. And I'd like to acknowledge initial pilot funding from Servier. So I hope this Grand Rounds will provide something for everyone. And as an outline to the story, I will start by telling who I am, who we are as a GI division, and I'll put in a shameless plug about our division. Then we'll turn to highlighting the burden of drug adverse events and specifically drug-induced pancreatitis. We'll focus on the prototypic example of asparaginase-associated pancreatitis, and I'll tell you about a systems approach that will reveal a potential therapy. I am a physician scientist who came to the US as a first-generation immigrant from India. I grew up in Brooklyn, New York, studied in upstate New York, Boston, and then New York City. My first job was at Yale and thereafter at the University of Pittsburgh. And why I came to Stanford in 2019 was to marry science and medicine. And I have the privilege of serving as chief of an awesome division of pediatric GI. And here's a snapshot of our faculty and staff at the 2019 annual retreat. There are several new faces who are not in this picture. The vision of our division is to serve as the preeminent provider of pediatric GI care in the region and to emerge within a short time frame as a global leader in pediatric GI research and education and a destination site for highly recognized programs of excellence. Our mission is to heal children with digestive disease through innovation. And there is a longer byline, which you can read, which emphasizes the value of partnerships. And this theme of partnerships is a common thread in today's story. To achieve this mission, we continue to bring out our core values and aspirations, as shown in this word cloud from our last annual retreat in 2020. And the three that emerged are unity, mutual respect, and program development. Indeed, we are a division of positive change, as attested by recruitment of over 70% new faculty in the last 3 years, and a jump in the rankings in US News and World Report to the number 13 spot. And we have ambitious plans for sustainably ranking in the top 5 or 10 over the next decade. And although there's a whole dynamic group for US News and World Report from the hospital, I wanted to highlight 2 individuals in particular who lead the effort from the division, and they are faculty member Lina Al-Rabadi and Executive Director Francesca Pae. Our clinical programs of excellence are growing, as shown in the spiral of programs, many of which are highly interdisciplinary. There are many responsible for operating the wheel you see here. But 3 in particular in our division are at the helm, and they include Naseem Kavari, Associate Chief of Clinical Affairs, Francesca Pae, and Tan Villawancha, who's our division manager. In addition to establishing clinical excellence, another strategic initiative is to leapfrog into the research lead by embracing emerging technologies today. Again, there are many people who are integral to this strategy, and in our division, the efforts to leapfrog are led by Zach Sellers, Associate Chief of Research. Within the division is our lab, whose mission statement is making breakthroughs in the pancreas and beyond that benefit society and patients through innovation, partnerships, inclusion, and integrity. And the 3 research areas are the ones that Mary has mentioned: the pathways that initiate and transduce pancreatitis, the factors that turn on pancreatic regeneration and recovery after injury, and the mechanisms underlying specific forms of drug-induced pancreatitis. And shown here are pictures of our dynamic lab team. Well, let us focus over the next few minutes on one of those research areas, which broadly addresses the problem of drug adverse events. To give you a sense of the enormity of the problem, there are over 21 million adverse events reported in the FDA adverse events reporting system, or FAERS, and most of them have been reported since the last decade. Roughly half are reported by consumers and half by healthcare professionals. And I would presume that few of you in this audience today who are healthcare professionals have filed an FDA adverse event. But most of you could recall several adverse events that you have observed and not reported, which tells you that as high as these numbers are, they are still a gross underestimation of the true burden of drug adverse events. We will focus our attention on acute pancreatitis, which is a serious drug adverse event. Acute pancreatitis is a painful, life-threatening disorder caused by inflammation of the exocrine pancreas. An operational definition of acute pancreatitis is the presence of two of the following three symptoms or signs, including typical abdominal pain that is epigastric and radiating to the back, a serum lipase or amylase that is greater than 3 times the upper limit of normal, or characteristic imaging findings of edema, pancreatic or peripancreatic fluid collections, or necrosis. It turns out that drugs are a leading risk factor for acute pancreatitis in children. On the left is a retrospective study of about 500 pancreatic cases from our research group when we were at Yale New Haven Hospital. And it demonstrates that medications are the second most common risk factor for acute pancreatitis in children, with a frequency of about 1 in 5 cases. A recent study from a prospectively enrolled pediatric acute pancreatitis database by Maisam Abu al-Haija at Cincinnati Children's similarly demonstrates that medications are a leading risk factor. I have highlighted Maisam in this picture because she is part and parcel of the current story that I'm about to tell you. By contrast, you can see in this pie diagram that medications make up a much smaller proportion, as low as 2% of pancreatitis cases in adult reports. Why is there a discrepancy in the frequency of drug-induced pancreatitis in children versus adults? I believe there are 2 major reasons. And the first is that there are in operation different definitions. The adult definitions require that other etiologies are first ruled out, whereas pediatric definitions are more inclusive in that they generally use the term risk factor rather than etiology. The reason for this is based on the premise that pancreatitis results from the convergence of more than one risk factor. Thus, pediatric studies make a diagnosis of drug-induced pancreatitis even if other risk factors for pancreatitis are present. The second major reason for the discrepancy is that children are more likely to receive drugs that cause pancreatic injury. When we allow for more than one risk factor to exist, we find that at least 1/3 of children with drug-induced pancreatitis have concomitant risk factors. And this point is shown from both the study in New Haven on the left that we had performed and the one in Cincinnati from Maisam Abu al-Haija. The second major reason for a larger frequency of drug-induced pancreatitis cases is that children are more likely to take drugs that are associated with pancreatitis. On the left are data from our study in New Haven, and these data are similar to what the Cincinnati group recently published. And on the right is a list from an extensive literature search performed by the Hungarian Pancreatitis Study Group. And what you see is that among the major causes of pancreatitis, valproic acid and asparaginase are drugs that are primarily ingested by children for pediatric epilepsy and acute lymphoblastic leukemia, respectively. Thus, as pediatricians, we have special access to patient material to ask why some drugs induce pancreatic injury and why only some patients develop pancreatitis with exposure to a particular drug. Importantly, how we might identify patients who are at risk before they receive the drug and thus prevent pancreatitis or provide a rescue therapy. To answer these questions, as physicians and as scientists, it is helpful to focus on a prototypic example and a specific drug. I would like to draw your attention over the rest of this time to that of Asparaginase-Associated Pancreatitis, or AAP. I was intrigued by AAP since the first profound case I saw as a junior GI attending on the wards over a decade and a half ago. The young adolescent boy I saw was taking asparaginase for ALL and developed severe necrotic pancreatitis, causing loss of most of his pancreas. I kept asking in my head for years why he developed pancreatitis with asparaginase and whether there could have been a way to avert the adverse event or to rescue it. Asparaginase is a crucial chemotherapeutic for the most common cancer in children, which is acute lymphoblastic leukemia, or ALL. The drug was instrumental in transforming survival from 10% in the 60s to now greater than 90%. However, pancreatitis develops in 5 to 10% of users, and 1/3 of users develop severe pancreatitis. To emphasize the impact of the problem of AAP, there was a study of recent that pooled raw data from 26 ALL trial groups run by 18 international trial groups. And this work was compiled by the Nordic group and by Kjeld Smegeloff and Ben Walthers. And from this, they identified 465 patients with asparaginase-associated pancreatitis. What was sobering is that 8% of this group required mechanical ventilation, 26% developed pseudocysts, 21% required acute insulin therapy. 1 year after AAP, 11% still needed insulin, and 8 years after AAP, 9% still needed insulin. From these data, AAP is generally a more severe form of pancreatitis than the other risk factors. What has also become apparent is shown in the graph of event-free survival versus years from diagnosis, which is that there's been a dramatic improvement in childhood ALL survival over the last 50 years. And this improved survival has been in large part due to more intensive asparaginase therapies, as shown in the various comparison studies. And truncating therapy due to AAP could increase ALL relapse. Thus, while asparaginase can cause several adverse events, pancreatitis has emerged as among the most important complications to prevent or to treat. There is thus a major unmet need to decipher the mechanisms of AAP and to come up with methods to predict or rescue the problem. A systematic review we performed revealed only limited risk factors for asparaginase-associated pancreatitis, including older age, asparaginase formulation, higher ALL risk stratification, and higher asparaginase dosing. What became clear was that the existing data about AAP fail to explain the underlying mechanisms. The genetic associations with AAP published of recent were also unclear. Listed are some of the genes identified by candidate approaches or by genome-wide association studies, or GWAS. Part of the problem is shown in this Manhattan plot, which is that many of the hits from the GWAS fail to reach the threshold for genome-wide significance. And when they do, they fail to be validated, such as the single nucleotide polymorphism, or SNP, which maps to the region of NFAT-C2 as shown here. To make a serious attempt at identifying novel factors that could impact AAP, we decided to take a systems approach. The term systems approach has a broad definition, and what it means to me is really using multiple methods to put pieces of a puzzle together or leave no stone unturned. As with the Pacific Coastal Highway in many parts, as shown in this picture, in a systems approach, there will naturally be many twists and turns. And so let's take that road. To interrogate AAP, we began with the FDA. That is, by data mining the FDA Adverse Events Reporting System, or FAERS, for clues, using a novel informatics tool called AIRS-MINE that was developed by our collaborators at Cincinnati Children's. And they're shown below, Mayur Saragdar and Anil Jega. The schematic on the left shows that drugs can be assigned what's called a risk score for a particular adverse event. In this case, drug-induced pancreatitis. In many reports, there are secondary drugs reported besides the ones that are reported for that adverse event. And we can exploit this point using the tool because those secondary drugs can potentially lower or increase the risk score associated with the primary drug. Thus, panel A shows a heat map for several drugs that are primarily reported to be associated with pancreatitis, or what's called Panc Plus, on the top rows in pink. Below the pink are drugs shown by the green that reduce the pancreatitis risk based on an inverse correlation of an absence of reporting. What panel B shows is a schematic of screening the millions of FDA records for reports where the pink drugs were taken concomitantly with the drugs in green that were inversely correlated with pancreatitis. Panel C shows actual data for pancreatitis risk in a heat map with those inversely related drugs. While some of the immunosuppressives show up, you can make them out: adalimumab, etanercept, rituximab. The green arrow points to a surprising entity, which is vitamin A. Now, if we home in on those data, we see, as shown in the heat map, that vitamin A exposure appears to mitigate AAP. These are highly provocative data, but they beg many more questions that the FAERS is unable to answer, such as the route of administration of this vitamin A exposure. And frankly, topical vitamin A derivatives are common acne medications that are applied in pea-sized quantities. So how do you sort out the topical versus oral or systemically delivered vitamin A agents? Another question is the timing of vitamin A exposure relative to asparaginase. Finally, these data are heavily based on non-professional consumer reporting, which adds another layer of complexity. To tease out some of these questions, and to start with specifically separating out the systemic versus topical administration of vitamin A, and to follow up on the primary findings from the FAIRS, our collaborative team led by Mayur and Anil and aided by MySum turned to the electronic health records through a database called TriNetX, which allows you to compare outcomes between specified cohorts from 64 million records across 41 different healthcare organizations. We can use the TriNetX data to come up with two groups, one that took asparaginase and in whom vitamin A exposure was excluded. The second group took asparaginase and had non-topical vitamin A exposure. Pancreatitis was identified by ICD-9 coding for pancreatitis by a physician provider, and pancreatitis was counted only if the diagnosis was coded within a 5-year period of first exposure to asparaginase. So we get some level of definition here. Only patients who had no prior history of pancreatitis were included in the two groups. The data are further refined by age matching because age is a confounder for AAP. What we see after this stringency of inclusion and exclusion, firstly, as shown by the black bar, is that the frequency of pancreatitis among asparaginase users without vitamin A is close to 8%, which is within the frequency range in the literature. So that's an internal validation. But the second and more striking finding, as shown in the maroon bar, is that vitamin A exposure mitigates AAP with an odds ratio of 2. AAP in the previous slide was defined by ICD-9 codes, which is a physician-based coding for pancreatitis. The power of the electronic health record is that we can also data mine patient lab data. If we now use the serum amylase or lipase levels, this time not to diagnose pancreatitis, but as a surrogate marker on a continuum of pancreatic cellular injury. And then if we define thresholds or cutoffs for pancreatic cellular injury using those surrogate markers, we find, as shown for the serum amylase thresholds on the left and the serum lipase thresholds on the right, that systemic vitamin A exposure mitigates AAP or asparaginase-associated pancreatic cellular injury in this case. The use of big data has its strengths with a large number of records, access to multi-center and real-world information, and the power of screening for hypothesis generation. The limitations are the uncertainties about reporting, that drug dosing is not available, that the route of administration and timing of concomitant drug use are not precisely provided, and the non-prospective nature, all of which requires complementary methods for validation. Notwithstanding the limitations, our big data identified vitamin A as a potentially protective factor in AAP. Vitamin A refers to a group of fat-soluble retinoid metabolites, various metabolites that modulate vision, reproduction, immune function, and have broad effects on fundamental cell biological functions. Most of the effects are through ligand binding of several retinoid-related receptors that affect transcriptional gene regulation. And vitamin A is derived in the human diet from both pre-formed vitamin A from animal sources and provitamin A carotenoids from plants. To further probe the role of vitamin A in AAP, we asked whether there are changes in the retinoid metabolites or related pathways that differentiate patients who go on to develop AAP compared to control cases who do not develop pancreatitis. For this, we performed an untargeted metabolomic analysis using a case control Design. Metabolomics is a comprehensive quantitative analysis of metabolites in the metabolome under a given set of conditions. A metabolite is broadly defined as any substance less than 1,500 kilodaltons in size that is an intermediate or a product of metabolism. And listed here are several categories of metabolites. Data from metabolomics provides a detailed functional analysis of an organism which can be integrated into the schema of systems biology. Here is a schematic of the case-controlled design of age, sex, and initial ALL risk matched ALL controls, schematized on the top, and cases on the bottom, who went on to develop pancreatitis. In most cases, as shown by the histogram, 3 months after induction therapy. The plasma samples were taken at 2 early time points. Firstly, at baseline, that is prior to induction, and secondly, right after induction therapy. Importantly, both samples were taken in most instances before the onset of pancreatitis in the cases. This is, I would underscore, a powerful setup to test for predictors or predisposing factors in pancreatitis. During induction, the subjects received only 1 dose of asparaginase, shown in the red on the timeline. This particular protocol comes from the Dana-Farber Cancer Institute ALL Consortium, led by collaborator Louis Silverman. From this case control group, we first asked whether there are differences in the metabolites between cases and controls at baseline. The differences in expression of the metabolites between the 2 groups will be shown on what's called a volcano plot, which factors in the impact of the change on the x-axis and the level of statistical significance on the y-axis. And because it's logarithmically transformed, in this plot, you should focus on the lava at the outskirts. The volcano plot here is unimpressive and flatlined, which means that at baseline, that is prior to induction, there are no statistical differences in the metabolites between the cases and the controls. But don't lose hope, because we next asked whether there are differences in the metabolites between the cases and controls now after first exposure to asparaginase, which importantly is still prior to the onset of pancreatitis. We reasoned that the differences between the 2 groups could be brought out by a single exposure, sort of like a tensilon test is used to provoke changes of myasthenia gravis, as an analogy. As shown in blue, the additional power of this analysis is that we can perform a paired comparison of relative change before and after induction therapy for each subject. And we struck gold. What we discovered was striking, which was that when we looked at the change or ratio of post over pre-induction in the metabolite panel paired for each subject among all of the metabolites, as shown in this volcano plot, the plasma retinoid precursors were reduced in abundance in the AAP cases. The red arrow conveniently points to the provitamin A precursors, the carotene diols. Furthermore, as you can see in the enrichment plot, and as denoted by the red arrow, pathway analysis revealed vitamin A metabolism as a top hit. When we examine the 5 metabolites identified from the retinoid group, we see that the plasma retinoid precursors, shown in the x-axis on the right of each of the panel graphs, for pancreatitis failed to increase in those AAP cases after first exposure to asparaginase compared to the controls, which are on the left of each of the panels. The heat map on the bottom right shows that each of the 5 metabolites correlate with one another. That is, they track together. Even though the two groups had no differences at baseline in terms of metabolites, ALL patients in general have nutritional deficiencies. Broadly speaking, therefore, could the pancreatitis cases have been more profoundly malnourished than the control cases, such that the cases had reductions in nutritional handling after induction therapy? Were other vitamin levels reduced between the cases and controls? In addition, pancreatitis causes transient exocrine pancreatic insufficiency. This could lead to subclinical fat malabsorption. Vitamin A is a fat-soluble vitamin. So specifically, could the reduced abundance of vitamin A in the pancreatitis cases be due to transient exocrine pancreatic insufficiency and subsequent malabsorption of fats? This would seem unlikely, since the plasma samples were taken prior to pancreatitis. Nonetheless, we asked whether the other fat-soluble vitamins or other vitamins were reduced between the cases and controls. The limitation is that only a few other classes of vitamins were detected in this particular metabolomic analysis. Nonetheless, we found, and what are shown in thumbnails of the data, is that upon induction therapy, none of the other vitamins that were detected besides the vitamin A were different between the cases and the controls. Now, when we look again at the histogram of pancreatitis cases, we see that there is an early pancreatitis cluster among the cases. And if we further divide the cases into early and later pancreatitis groups, we find, interestingly, that the early pancreatitis cases had lower levels of the retinoids and retinoid precursors, which further lends support to an inverse correlation between pancreatitis impact and retinoid levels after induction therapy. I hope you've been following me, and just in case you weren't following everything, here's an interim summary. We found from the big data reporting and health records that concomitant vitamin A use mitigates AAP risk. We also discovered from the metabolomics data that reduced vitamin A or retinoid precursors are associated with the development of AAP. What we must acknowledge, though, as shown in this list of drugs given during induction therapy for ALL, is that asparaginase is among several drugs that are administered. It's not the only one. Since there are no studies of asparaginase use alone in subjects, there is no way to know from the clinical data whether asparaginase as a single agent leads to a reduction in retinoids. And there are other important questions which arise, including what the impact of retinoids are on pancreatic health. To tackle these questions, we turned to experimental animal studies. And these are studies from our collaborators at Rutgers, Tracy Anthony and Loredina Quadro. They found in preliminary data that asparaginase as a single agent administered to mice indeed causes a reduction in both serum and hepatic retinol. And the trend of reduction in at least the serum retinol occurs independent of age, sex, or diet. We have several experiments planned to examine the impact of retinoids on pancreatic health. In the meantime, Here is another plug for the power of big data analysis. Anil Jega from Cincinnati Children's asked this question by taking open source transcriptomics data from papers published in leukemic cells and from bulk pancreas of mice after experimental pancreatitis induction. Let me walk you through this diagram. The left top Venn diagram shows that there are 127 genes that are upregulated in the leukemic cells and that are expressed in the pancreas. The bottom left Venn diagram shows that there are 224 similar genes that are upregulated in the pancreas during pancreatitis. When you run both sets of upregulated genes through an in silico screen for compounds that are predicted to what's called anti-correlate with the gene expression profile, you find, as shown in the heat maps, that for both screens you get a similar result, which is that the retinoid analogs are among the top hits that are predicted to prevent or reduce the pancreatic gene upregulation. This is fascinating data because here again is another independent interrogation. In fact, this is a starting point for us to test those compounds and their cognate receptors in the context of pancreatitis and pancreatic health in experimental models and ultimately in the clinic. There are many more questions which emerge relating to vitamin A on AAP, including how much vitamin A is necessary for a protective effect. What is the identity of the carotene diols? What is the fastest route to data validation and a parallel multi-omics approach to provide greater mechanistic insight? What is the mechanism by which asparaginase reduces the levels of the systemic retinoids and retinoid precursors? Are the retinoids central to predictive modeling for AAP? What is the fastest pathway to clinical trials of retinoids to prevent or rescue AAP? Does vitamin A affect the other adverse events associated with asparaginase, which would have implications for the design of clinical trials? Although pancreatitis is a major asparaginase-associated adverse event, there are several other asparaginase-associated adverse events in patients with ALL. Based on these events, we could put together a radar plot to ask whether the retinoids protect against the other adverse events associated with asparaginase, and if so, to what extent. And what's shown in green is something I just made up, which is a hypothetical answer. But imagine if we had an empirical answer based on studies. By tackling questions in drug-induced pancreatitis, such as with asparaginase, we might be able to imagine a future for a personalized approach in which the clinician and inputs history and anthropometric data, genomics, possibly even other omics into the electronic health records. And what is automatically outputted for that particular patient based on those data are what drugs to avoid or to use judiciously, or more importantly, what prophylaxis to employ in order to avoid the complication of drug-induced pancreatitis. In summary of what I hope was an interesting story to you, drugs are a major risk factor for pancreatitis, especially in children. AAP, asparaginase-associated pancreatitis, is a prototypic challenge to undertake, one that piqued my interest because I was perplexed by one patient that I saw many years ago who had such profound lingering AAP. And sometimes it takes that one patient to drive you towards a career. Our systems approach to AAP suggests a therapeutic role for the retinoids. And these findings have implications for prevention and rescue of AAP. This also highlights the benefit of using a pediatrician's lens to visualize drug-induced pancreatitis. And it serves as a broader paradigm for a systems approach to address drug adverse events. So with this, I thank you for your attention.
Okay, should we jump into the questions?
Really?
There's some good ones and a lot of interest in vitamins, and it was really wonderful to see the metabolomics connection and all the mechanistic piece and all of this. So I'm just going to start right at the top. Why isn't alcoholic pancreatitis in adults considered drug-induced?
Well, it is. I mean, I guess you could technically call it a drug-induced, and then in that case, it would be the #2 cause of acute pancreatitis. The FAERS doesn't capture it. We, traditionally don't think of alcohol as a medication, and so this space is really suited for a medication-induced pancreatitis, and that's the context of drug. So
I'm a little bit out of order because I think that might be a better follow-up. So it said, do you mind reviewing the other top medications associated with pancreatitis?
Oh, certainly. In fact, we've got a really interesting paper on the other common reason, which is valproic acid. Now, probably won't have time to go into much detail, but maybe the 30 to 60-second response is that this is fertile ground for a lot more very interesting, exciting, and potentially broader implication-related research. And the short story is that valproic acid is used as a pharmacological tool because it's a weak inhibitor of the histone deacetylases. And so we thought that it somehow changes the chromatin remodeling and prevents some aspect of the protective mechanisms against pancreatitis or recovery. And what we found was that indeed it impedes recovery of the pancreas. So that was just another example of another drug-induced cause that has a mechanism that's really worth probing further.
All right, and then before we jump into some of the vitamin A related questions, somebody asked if you also looked at vitamin D.
We have not, and it did not come up in the screens, but there is quite a lot of literature about vitamin D for adverse events unrelated to pancreatitis and asparaginase, and vitamin D for chronic pancreatitis, at least experimentally. We're not sure that it is a factor in acute pancreatitis. We haven't seen it. We haven't rigorously tested it, but certainly worth thinking about.
Yeah, I think the other part of vitamin D is the whole questions around vitamin D and endocrine, the endocrine function in the pancreas. I think there's actually the 1-alpha hydroxylase, I think, has been implicated in beta cell function. So I think the vitamin D pancreas story is very interesting. I hadn't thought about it in the context of exocrine pancreatitis, exocrine pancreatitis. So thank you for that question. Okay. And the questions are moving in order. So up to the top now is, do you anticipate a randomized controlled trial to test the effects of supplemental vitamin A treatment in advance of asparaginase treatment?
Yes. The short answer is yes, resoundingly. And in fact, this is where we should really start talking, because this may be enough impetus to conceive of a trial. We may want to do more of a experimental animal study to look at the various types of vitamin A. There are something like a dozen vitamin A derivatives. There are about half a dozen that are commonly used. And so to test them could be the next steps, but doing a pilot trial might be worthwhile in parallel. And Tanya and team, we certainly could use your help.
Yep, they're here. We've got some good questions from your oncology colleagues are coming up. But let me first say, is vitamin A exposure related to Apml? Do Apml patients get less L-asparaginase compared to ALL patients and thus have a lower risk for AAP? for acute pancreatitis?
Great question. I was, in fact, I should look that up. The APML patients have a rearrangement in the retinoic acid receptor, or one of them, and so ATRA, all trans retinoic acid, sort of become a mainstay of therapy. I really lean on our oncology folks to look at the intricacies, but I will actually look that up in more detail. I didn't know that they were given asparaginase and to what extent, and it would be interesting. It's a rarer disease, so there might not be as much data as with ALL, which is the most common cancer in children, but certainly worth looking at. So thank you.
Good question. Okay, and then from Alka in your division, is the vitamin A metabolome difference between cases and controls due to intake, or could be due to underlying metabolic defect which predisposes patients to retinol deficiency, and higher doses can mitigate it? This is a multi-part question, so I'll stop there.
Elka, great questions, and thank you. We can say for sure from our metabolomic data, again, it's not like a huge number, it's still a relative pilot, is that at baseline, there were no differences in the retinoids. So we don't think that they start off the same, but there's certainly something that pushes them, the pancreatitis patients, into a lower category than the non-pancreatitis patients. And whether it's a genetic predisposition, environmental factor, the microbiome, circulating levels of retinoid binding proteins, which Laura Dina and Tracy from Rutgers suspect, and have some interesting preliminary data about, is sort of all open to interrogation.
And then we have a couple of oncologists who want everyone to know we do not use asparaginase in the treatment of APL. Children with APML don't get asparaginase. Okay, thank you. That's why it's so wonderful how transdisciplinary this Grand Rounds is. Okay, back to Alka's question. Another follow-up: are other drug-associated pancreatitis affected by vitamin A deficiency?
That's something we want to look at for the thing that we're putting together, or the first set of work, and we don't know that yet, and that will be a fair interrogation to start with. I can tell you the flip side. So you asked whether vitamin A works for other drug-induced pancreatitis besides asparaginase. I can tell you that for the other adverse events, sort of like that spider plot that I had shown of asparaginase, it actually turns out that vitamin A from the TriNet X, because of ICD-9 diagnosis codes, and we looked at those 5, the ones I showed in the spider plot, are actually impacted by vitamin A. So this may be the clinical trial to go with.
Okay, good. And then Sunny, one of your neighbors in the lab, said, are there Snips in humans that determine the rate of metabolism for retinoids? Do these have any impact on susceptibility to AAP?
Thank you for asking that. I didn't think about that, and I would need to write that down and look it up, but I will, and certainly an important question. I appreciate it. Okay.
And coming back to our oncology colleagues, Norma Kyle said, is there any role for dyslipidemia and lower vitamin A metabolites, and a role of a high-fat diet?
Possibly, at least from the animal data, there wasn't too much of a difference in the retinoid levels with or without a high-fat diet when you gave asparaginase. But you know what, those were just a few N's, and there may be a role, at least the literature would support a role. We just haven't seen a robust role yet, if I recall correctly.
Okay, and then one more question along that line, also from Norm. Are there age-related determinants of vitamin A metabolism? We usually don't see AAP in younger and low-risk patients.
Yes, absolutely. So, the vitamin A part, that's a great question. That's also interesting, and I'm going to write this down. The problem is once you start slicing the salami on the FDA records or TriNet X, you lose the ability to perform the interrogation because we just don't have the numbers, because you need a lot of numbers to control for all the confounding. But it would be interesting to know whether there is a age-dependent protection of vitamin A. To answer the first question, there's definitely a increased risk of AAP in adolescents and older adults compared to children, younger children.
Okay, and Sohail, I've copied all these questions and pasted them into a Word document I will send you, so you don't have to worry about writing these down. One more on a little bit different direction. And do these vitamin pathways reflect on the association of pancreatitis and anorexia nervosa?
Great question. So what does asparaginase do? It causes a nutrient deficiency. It causes depletion of a specific amino acid, asparagine, to nil levels in the circulation. And that's probably what really gets the leukemic cells, and then to a lesser extent glutamine, because it also functions as a glutaminase. I've thought about nutritional deficiencies in pancreatitis. There's this old literature about pancreatitis due to malnourished state, anorexia, so on. It's sketchy though, and it's rare. Of course, I'm going to be now proven wrong based on our feeding disorders clinic, but I will say that it is interesting. There may be a point here. It's complicated. We don't have an answer. I don't have an answer.
Yeah, it's a great question, and we have a really extraordinary eating disorders program, Sohail, here with a big unit down at El Camino, so there might be some opportunities there. Okay, the last question comes from Ken Weinberg, and there's a lot here, so buckle up. Nice talk. Retinoid metabolism intersects with multiple aldehyde dehydrogenase pathways, including the ALDH2 isoform that is responsible for the alcohol flushing syndrome that is prevalent in East Asia. Any associations with ALDH2 polymorphism? Okay, I'll stop there. This is a multi-part question. And you can probably see the question too, Sohail, that might make it easier. But in any event, go ahead.
Yeah, just like Sunny asked, I will have to look into that. I'm not aware of a link, and that's the beauty of these data. So hopefully, with the same patients that we have, there was at least SNP analysis done, and maybe whole exome, and so we might be able to answer some of these questions about polymorphisms empirically.
Okay, that's great. All right. So, and then the last part of this is FAERS, so the FDA Adverse Event Reporting System, robust enough to detect excess occurrence in Americans of East Asian origin or have a history or family history of ethanol flushing.
To be continued.
To be good. Well, that says it should be at the end of Grand Rounds, right? Lots of really good questions. Loved the fact that we had a really great multidisciplinary series of questions, Sohail. So I think there's going to be some exciting follow-up questions. Perfect. Well, we're ending right on time. That was really exciting. And I love seeing the intersection with the metabolomics program and the oncology. So congratulations on a wonderful Grand Rounds. So,
thank you.
Okay. Have a great day, everybody. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.